Okay, so what I'd like to do, again, is try and join the dots between the engineers, the academics, we've had pharmacists, we've had people who make UV air cleaners, all try and come together around this whole concept of indoor air quality. I'm going to relate, I know Doug is speaking after me, he's going to talk about the new Centre of Excellence for IEQ, and how we correlate to good IEQ to clinical outcomes of keeping people healthier. And if we're going to have an IEQ standard with health indices, then do we need biomarkers that actually measure clinical outcomes of wellness of people? And then I'm going to look at the technical feasibility of doing that and then market adoption. A lot of this comes from an article that I published in the ASHRAE magazine, so if you want to read the full article, that's it there. I believe in my title, it's got AI in it. I think I'm going to do a talk these days. If you don't put I in it, it's not relevant. So I'm going to have a lot of AI in my talk, but really what I'm going to talk about is AIR. Okay. So you've got one group in the audience, which are people who design buildings, the architects, the construction engineers, the HVAC people. And then you have all the minutes on the other side, the allied healthcare professionals, pharmacists, doctors, and so forth. But how are we connected? So Bill and I were chatting at dinner, and yesterday, and the talk just now kind of drifted into how can HVAC and ASHRAE help us make better hospitals. And that's really important, just like the speaker there, about how hospitals can impact on the environment. So it's quite complicated. But what I would like to talk about is how can the buildings keep us out of hospitals so they're connected, but let's not have hospitals. We chatted yesterday about what will the future be with regards to the exploding population, and we heard Drew this morning talk about exploding population. Well, I think we've got to keep people out of hospitals. I think buildings have got a big role to play in that. So as I was doing some research, and I think Professor Helen did this a lot better, as well as Melina this morning. Actually, when Melina was talking, I felt I was in the movie The Da Vinci Code, with so many things in there. But I'm going to give you 2,500 years of history. So we know HYGEIA, and that's why we're here. And then obviously we're on the island of Hippocrates. I'm very excited. Antonius is going to bring us there. But they all spoke about the idea of wellness and staying well, and air was involved in that. Vitruvius, Melina spoke about him this morning. In his book, he spoke a lot about air and keeping people healthy. Marcus Aurelius was obsessed about indoor air quality. And then Avicenna, who was the Islamic Empire, took on a lot of what Hippocrates did and actually brought it to the next level of modern medicine. Benjamin Franklin, for the Americans are here, he would speak a lot about cleanliness and hygiene and stale indoor air. Florence Nightingale, interestingly, the hospital in the UK during the pandemic was going to be the Nightingale Hospital. She spoke about this idea, the first rule of nursing and keeping people well is about indoor air quality. Then we have John Snow, okay, that was cholera, but his dot theory in dotting the outbreaks actually gave rise to modern epidemiology, which we were then allowed to use in the pandemic. Then obviously you've got Pasteur and Koch, and then this idea of there's bad air out there, there's a miasma, there's bad air, that ultimately turned into the germ theory. And I think maybe a little bit, when we got away from the miasma, which was a bit fluffy, we spoke about health and wellness. When we're able to target germs, we got too obsessed about medication and tablets. And I think when Melina was speaking earlier, I really like those ideas about the Asclepians where they were, good? It's too noisy. Too noisy, good, okay. It's not the first time I've been told it's too noisy. So I like those Asclepians because they had music and chanting and theatre, and it sounded like a wellness or restorative or regenerative. And then when I heard Hippocrates came along, it was medicine and tablets and treating sickness. Maybe we need to go back to more the spa and the wellness rather than just treating people with tablets. Then you have William Wells, which gave rise to the Wells-Riley equation, which gave rise to ASHRAE241, that brings us all the way back to the chairman of ASHRAE241, which is Bill. So there's all the way from a Greek goddess to Bill Bampert in the room for 2,500 years. So Asclepius, we know about him. We've spoken about that a lot. Interestingly, the serpent in Greek mythology was regeneration, it was life, and that's why the World Health Organization uses that logo, and it's why the blue star in America uses the logo as well. But the Air Corps and many private hospitals in America actually use the rod of Hermes, which is of the god of Mercury, and it's actually the rod to represent business, commerce, transaction, and alchemy in tricking people. So that typo that the American private hospitals use, it's the wrong symbol. Maybe that was a forewarning of what would happen to some aspects of the US healthcare system as we go forward. So that's the wrong logo. So Acephalus, we've heard about Asclepions. He had two daughters. He had many children. He had two daughters. He had HYGEIA, which is the name of his conference, but he also had another daughter, Panacea. And it's quite interesting. HYGEIA was proactive, it was wellness, it was predictive, it was staying healthy, whereas Panacea, this idea that we're still chasing today, a magic bullet, a magic tablet, there's a shop for this, there's a pill for that, let's pay money for tablets, rather than do the hard work and staying healthy. I think that's going to be a recurring talk in my theme. And I got into this whole connection between the built environment and health and wellness outcomes as it relates to kids with asthma and allergy. So kids would come and see me, they'd be in the ER, and I would say, what triggers your symptoms? Where is it showing up in your indoor environment? And if you want to get a very modern example that the indoor environment is absolutely connected to health and wellness outcomes, this is the National Institute of Health guidelines. And before we give anybody any tablets or any medication, as a doctor, we're supposed to start with patient education in environmental control. And then we're not supposed to increase the medication until we've gone back and check their environment and assess their environment. Say, well, where's the allergen showing up? I should not increase your medication until I've validated your environment. So there's a really modern example of the environment and health outcomes being linked. It's there in the medical guidelines. And there is this concept of the exposome that is becoming more and more. I think Stephanie Taylor's done a lot of work on this. And there's the idea that we have our own personal exposomes. We have our gut bacteria, we have our skin bacteria. We then have our biological responses, and we have the external exposome, which can be the indoor environment as well. And they're always interacting. In VOCs we heard about this morning are having inflammatory reactions which are impacting on your physiology, or an allergic reaction like asthma will then be sensitive to something in the environment. So this connectivity between them is ongoing all the time. And if you look at some of the research, the data, in America, they spend 80%, 90%, 85% of their healthcare budget, which is $4 trillion, on access to doctors and tablets and medication. But if you look at actually what determines health and wellness outcomes in society, it's our behaviors and our environments. And you can see the amount of money, 4% of that goes into a healthcare budget. So people are realizing we cannot spend $4 trillion on something that actually doesn't determine health and wellness outcomes. And they're beginning to join the dots that the indoor environment has a role to play in this. Now I'm not talking about infection or hospitals, I'm talking about keeping people well in communities. So this is my belief, and this is why I'm at this conference, is that yes, I'm an ER doctor and you have the surgeon on before, and you need these kind of medical heroes down there, down the red end, the reactive end of the spectrum. But if you go to, say, your family doctor, then your nurse, then your exercise coach, and then your mindfulness coach or your nutritionist, you're coming more and more down the spectrum to the green wellness aspect, predictive, keeping people well. And I firmly believe that buildings and healthy buildings, you're not doctors, but you play an important role in keeping society well, and that's how I want to join the dots here. And I'm not a building engineer, but this is my way of thinking it. Yes, you've got buildings, they must be safe. They can't fall down, or else you end up in the ER with a head injury. And then we had toxic buildings, we had sick building syndrome, we had Legionella, we have all those things. But really what I want to talk about is, yes, indoor air quality, but even going further. Milena spoke about the idea of a healthy building, the idea of aesthetics and spatial buildings. Or should you have a quiet area in an airport for autistic children? Is that really what a healthy building is? But how do you engineer that in? So it does get complicated, but we have to have the conversation down here. And we also had a question about, should we knock all the buildings down and start again? I think there's an amazing opportunity. While we're retrofitting buildings, there are energy opportunities. We can do what I call the 3 Ps. We'd be great for profit, so operational carbon. We'd be great for the planet, i.e. sustainable buildings, but we could also be great for people. So in our drive for operational carbon and energy and net zero, why don't we use that to make healthy buildings as well? So we know as engineers and as scientists, we can do certain things for buildings that will improve buildings. And now with modern technology, we know what we do to a building, we can actually measure the building has better parameters that are supportive to health and wellness. What we don't have is a lot of data. That's why I thought Julia's paper was really interesting this morning. It was the first time, right, we know what to do, we did it, and it worked, and people were healthy. There's very, very little data on that. So this is an area of biology. Bill mentioned this morning about chamber effectiveness testing. So this is the type of aerobiology chamber we have in Dublin. We can put UV lights in here, we can put air cleaners, we can recirculate the air, we can inject in viruses. We can validate technologies, and we know it will kill a virus, it will kill a bacteria. We can go reactive air and surface technologies. We had to speak about titanium dioxide fluorine. We can put that all in there. But still the missing point is we don't know, does it actually keep people healthier when we put all these technologies into a building? So one of the other things I think buildings must be going forward is they must be kind of reactive, they must be responsive, build against low-impact infection, risk management mode. This again, some of you have seen this diagram before, but if you look at the axis here, you've got the various populations, the vulnerable population and the standard population. On the other axis, you've got situations, so special situations and normal living. So if you've got the normal population, if you've got a very special situation, such as an outbreak of a virus, you go to risk management mode of ASHRAE 241, or if there's wildfire, it's guideline 44. Or if you've got a vulnerable population in a special situation, you have ASHRAE 170. So the ASHRAE standards, you can actually map them over how they adopt for health and wellness outcomes. Not building, not engineering, not sustainability, not the planet. The ASHRAE standards are actually beginning to be more and more responsive and adaptive to people. Why is this important? Those of you who are familiar with this is AWAB's law. It got passed through the British House Department. It's now in law. This child died. It was the coroner's verdict was indoor air quality due to mold where he lived. And there's now AWAB's law that the professional indemnity of the landlord around people's health lies with the landlord. There's a massive shift now within social housing in the UK on sensor technologies because now they pay the bill. And tragically, until you find the money and follow the money, society won't change. But that will change in the UK. So if we need to do these, we need to have buildings responsive to people. The question then goes, well, can we use biomarkers? Is there something we can put on people, like a wearable like your iPhone that shows I'm in a healthy building? So a biomarker would be objective, it would give us data, and it could be precise, it could be matched to the pathogen or matched to the irritant. And we already have biomarkers which are sensors that we can put into building, and ARPA-H in the US are putting very large amounts of money through Jessica Green in the BREATHE program, where they're actually tendering out now for live biomarkers. But there's still physical markers to go into buildings. But I'm saying, can we measure something on ourselves that can show up in a healthy building? So what would a biomarker for a healthy building be? Well, it needs to be specific to the pollutant, it needs to be specific to the exposure pathway. Was it inhalation? Was it dermal? Did I ingest it? And they need to be stable. You can't have them degenerating. They need to transport them. You need to bring them to a laboratory. You can't be sticking needles into people, so it's got to be easy to get out, cost effective, etc. So is there a biomarker out there? Well, first of all, we need to look at the pathology of illness. So pathos, the Greek word for illness, so pathology or pathogen, anything that generates illness. So you've got to look at two things. You've got to look at the exposure pathway, and you've got to look at, is it chronic, chronos, another Greek word, or is it acute? So is it acute poisoning, or is it chronic exposure? So if I inhale something, like an allergen, the exposure pathway is the respiratory system, and it affects the respiratory system. But I can also inhale something like a microplastic, and when somebody has a coronary artery plaque, and you cut it open and look in there, there's microplastics in there, and they were inhaled. They crossed the blood-lung barrier. So indoor air pollution of microplastic is now causing coronary artery disease. So the exposure pathway was the lungs, but over time it ended up going to a distal organ as well. So a biomarker needs to think of pathology, it needs to think of the time, and also thinks of what the pathway, but also the target organ. So it can get complicated. So vital signs. You go to the hospital, take your heart rate, take your blood pressure, take your temperature. Good vital signs, we have them on our iPhone. Could they work? Not really, because I had to run here because I got caught in a thunderstorm, so my heart rate's up. So if the building, maybe not, I was falling asleep earlier because it was too hot, my heart rate was going down. Maybe, it's high blood pressure. What if I got blood pressure anyway? So vital signs are quite difficult. If my temperature goes up, well, I've already got the infection. So that's too late. It's a lagging indicator of exposure to an airborne pathogen. So they really are going to work. They might be helpful.
5 minutes.
There are new respiratory biomarkers. This incredible technology now. You can actually just breathe out with your VOC profiles. You can diagnose things like Alzheimer's disease. You can diagnose cancer. So you could potentially, at your work desk for a while, feel not great or being so every day, you blow into a thing, and it takes what we call a breath biopsy. Is that something we could use in the future? Blood biomarkers we know very well, drunk driving, drugs at work, all that kind of stuff. I mean, they're very good, but you've got to spike somebody and take a blood sample, even a thumb prick test. I don't really want to do that for indoor air quality. Although there are amazing examples of where we're using biomarkers, like the Limbo product, and people just put it on there, a sensory sensor. You keep your blood sugar between 5 and 10. If it's in the window, people lose weight. We can do it for diabetes management. So there is evidence of wearable biomonitors having clinical impact. Then you have urinary, salivary markers. You can even do genetic markers, but again, I think they're probably too complicated. The other biosensor is a wearable. The surgeon was just on there. Antonios is an interventional cardiologist. If you're working with live X-rays, you wear an X-ray exposure monitor. If you're working in a noisy building, you wear a sound monitor. So there are industrial hygiene standards for this. So is it taking some of that industrial hygiene and putting it into everyday work? The other biomarker, of course, is a survey. After every talk, we do surveys, people in Slido. So you could do more surveys. Joe Allen has done a lot on this Stroop test, which relates to high performance, high cognitive testing in CO2. So we could actually just ask people on a daily basis, how are you feeling when you're in this building? So just to finish up with a couple of slides. Kind of futuristic. Last time I said people had the International Space Station. This time we used Artemis. That was the mission. The great Greek word. Apollo was the first one. The actual the vessel, the craft they're in was the Orion, the Greek mythology. But in the Artemis 2 that recently went around the world, they're all wearing biosensors. The biosensors are all plugged into the building management system, and they're talking to each other all the time. Modern ICU beds, also the patient's wearing biomarkers, and it's plugged into the environment to be restorative, regenerative. They're changing light based on circadian rhythms. And interestingly, again, there's a question that came up by the Admiral, I'm not sure where he is yesterday, about prediction. We've got to have prevention, we've got to have prediction. Modern medicine will be about monitoring the environment. And interesting, when you sit in hospital, they'll monitor you, but when you're well, they won't monitor you. So I think that's going to flip. Why don't we monitor people when they're well while they're in ICU? But the problem is, even though we're all gathered here today, we haven't crossed this chasm. There's still an adoption there. And if you look at other technologies, such as home air conditioning, vacuum cleaners, flushing toilets, the adoption into society was much quicker. If I overlaid the adoption, I think people call it plaques for payment on buildings, official healthy buildings, and run it out over 40 years, we'll still have less than 5% of buildings who have adopted a healthy building policy. And if you compare that to HVAC and plumbing, it's not resonating with society, or something isn't coming together. So that's the challenge from here. So yes, it's technically feasible, but I think the big block here is market feasibility or commercial feasibility. Nobody owns the pain. The building owner, the person who sublets the building, the person who's renting the building, the HR people, the facilities management, everybody is kind of passing the thing around, and nobody has to pay the bill. And there are even companies now in America on an energy basis that will come in, they'll pay all the capex, they'll pay all the fees. There's literally no money down for you to have an energy efficient, sustainable building. It's kind of like a retrofit as a service. And I would like to see a new business model emerging about healthy buildings as a service linked to your health and wellness bill. It needs an innovative breakthrough like that. So I'll kind of finish up on this. Perhaps the future of healthy buildings is not new. HYGEIA and the Asepions, all those years ago, they realized, no, let's rediscover being proactive and staying well, rather than all that money, the double servant, of paying all that money. And this has been said, I don't think Mahatma Gandhi actually said this, but it's kind of attributed to him. The idea of what we're trying to do at this conference today, like healthy buildings, doctors speaking to ASHRAE, and getting everybody to come together with architects and facilities managers. First they ignore you, then they laugh at you, then they fight you, and then ultimately you win. And I think what Demetrius has started here, and what's happening around the world, is nothing as powerful as an idea that time has come. And time has come for healthy buildings that impact on the society. So again, let's finish on this. So maybe this idea, being on the island of Kos, and maybe Hippocrates did take us a little bit too medical and magic bullet, and more, maybe HYGEIA was never entirely forgotten, and maybe this conference is about rediscovering HYGEIA, and then she was just overshadowed for a bit of a time by her sister, Panacea. Thank you.